good to see everybody again, and it's been an interesting day, very interesting to think about the role of human rights and ethics and how that's affecting our implementation. I'm going to talk today about a project that we did in New Haven, Connecticut during the COVID-19 pandemic to look at contact tracing. And this talk was originally put together as a way of feeding back our findings to stakeholders and our funders. But I want to use it in a different way today, since we're at the end of this implementation science conference. I want to try to use this as an example of some of the things that we're trying to achieve in implementation science. And in that context, I think I'll share some successes, but I'll also share some of the challenges of doing it. And I hope that as you go through, you'll kind of think about some of the principles we've talked about in the last couple of days and how they're being applied here. In particular, I'm going to use it as a chance to, again, harp on theories and frameworks and how we attempted to apply those. There's going to be an opportunity for me to talk a little bit about qualitative methods, which you heard about yesterday from Ashley Hagman, and I think Sheila and others have kind of talked about their incorporation of those into their work. We'll also have a chance to kind of talk about some of the challenges of collecting routine data. So contact tracing is really, I think, an ideal example of an intervention that has a strong evidence base that goes across many different infectious diseases. And certainly we all recognize at the beginning of the pandemic, there was a tremendous amount of opportunity to adapt this intervention, originally developed for tuberculosis, applied widely for sexually transmitted diseases and other infections in this context of this new and emerging infection. And in that sense, it is the epitome of what I call a complex intervention. You might remember when we talked on the first day about implementation science, we said there's lots of different language or definitions or even labels that are used to describe it. And complex interventions is certainly one of those. So to take you back to March of 2020, you were dealing with your own challenges here in Malaysia, looking to China. We were also looking to China, and very quickly, by the middle of March, we had the first cases that were being reported in Connecticut, and I'll just grab my pointer here, since this is quite a detailed timeline. By March 14th, we had the first case that was reported in New Haven. About a week before, the first case was reported in Connecticut. I myself was working in the hospital this week and starting to see patients come in who were suspected of having COVID-19 and trying to figure out how we're going to test them. We had very few means of testing. On March 15th, the New Haven mayor declared a state of emergency. Yale Health, which is the health plan that covers Yale employees, was already starting to do some contact tracing by March 18th. And on March 27th, the New Haven Health Department, which is the public health department for the city of New Haven, reached out to my colleague Linda Nicolai at the School of Public Health and asked for some help in standing up a contact tracing program. And that was done, and by April 4th, the volunteers, mostly students and faculty at Yale, were doing that work. And the protocol that was used, there were two programs that were happening. I'm not going to talk so much about the Yale Health one, but I'll have you focus here on the greening, requiring us to use the state epidemiology database that was used for reporting communicable diseases. It had been modified to allow reporting for COVID-19. And that database was screened daily to identify new cases that were living in the city of New Haven. Those were compiled by the epidemiologists in the Department of Public Health. And then after some training of the volunteers, the names were given out and calls took place. We had two teams that were working. One team that was consisting of contact, case interviewers, and then another that was contact notifiers. Because it was felt to be very important at that time, given the stigma potentially associated with COVID-19, to avoid potentially unmasking who the index cases were in case they didn't want to be identified. Next slide. So I want you to hear, as I'm talking about, I want you to think about how might we evaluate a program like this based on the principles we've laid out. What are some of the IR-specific questions that we should try to answer? And which theories, models, and frameworks might we employ to understand this particular intervention? And as I mentioned, contact tracing is a complex intervention. We all know that the goal is to try to identify cases and report them in order to be able to identify contacts who may have been exposed in a period when they could then take action to quarantine themselves, get cases to isolate themselves, with the goal of providing information about COVID-19. At that time, we take it for granted now, we've all been so inundated, but thinking back at that time, particularly poor and marginalized populations that were we're serving in through the Department of Public Health, people that may impact insurance or other connections to get information. That was a very important function of conduct investigation, in addition to isolation and quarantine. And these services each have different goals. Of course, interrupting transmission was one that we all thought about a lot for contact tracing. And one of the goals of this evaluation was to try to understand, can contact tracing be delivered in a way that would be effective in terms of preventing ongoing transmission, shutting down chains of transmission. We wanted to be able to enable treatment and monitoring for people who might be diagnosed and maybe in the first week not be so ill, but then become much more sick and need hospitalization, be able to link them to care. Educate and counsel cases and contacts, and provide social and material supports. A lot of interesting information you'll see a little bit about the challenges that people had, supporting their families, not being able to work, having money to pay the bills, these types of things. So this is a little bit of an example of one of our public health nurses who is doing the calls alongside the students. And the study design that we used to evaluate the program was a prospective implementation cohort study with nested mixed method studies. We included all COVID-19 cases in the state surveillance system and their enumerated close contacts who were placed into a database that we designed in collaboration with the City of Public Health, the City of New Haven Department of Public Health, and focusing on those who were then addressed in New Haven City during this initial wave of the pandemic from April 4th through May 19th. We also did some work with the volunteers themselves. And under what conditions can COVID-19 contact tracing contain COVID? I think I'm actually going to skip over this slide, but the point of it was to just show that we needed to establish some type of indicators. And CDC, through some modeling papers that were published in the literature, established these two milestones that we sought to try to meet. One was identifying more than 60% of COVID-19 cases in order to be able to have a chance of interrupting transmission, in doing so in a timely fashion, so that within 6 days we would be able to reach people. So here are some indicators that we proposed. We basically adapted these goals to look at the cascade of delivery to try to understand, using really what you'd see here as a reading model, basically, combining also some of the outcomes from Proctor's framework to understand how well could we reach cases and contacts, how timely could we be, given the concerns about being able to reach people before they engage in ongoing transmission. What's the overall yield, if you look at all these different steps as we do with cascades, what proportion of the people that we can have an impact on are we reaching? Equity, a big concern. Early data that came out of the pandemic at that time helped us recognize that individuals from minority backgrounds in the U.S., primarily people of Latino background or Black race, were at 2, 3, 4, 5-fold increased risk of developing COVID and also having death and other severe adverse outcomes. Looking at the number of contacts preferred per case and volunteer retention. And ultimately, that was our wish list of things that we were wanting to be able to get, but not all of those pieces of information were collected during this public health emergency, and so we can only look at some aspects of it. One thing that's missing here is how well people adhere to isolation and quarantine, because that information was not available. So our data collection methods included process evaluation, looking at that surveillance data, calculating all those indicators, and understanding the time using time series methods, and then actually not time series methods, but survival analysis methods, and then looking at fidelity and context using focus groups with volunteer tracers and interviews with cases and contacts. So I'll describe the results of 3 manuscripts that came out of this work. The first is this quantitative manuscript published in Frontiers of Public Health, entitled Lessons Learned from COVID-19 Contact Tracing During a Public Health Emergency. So first of all, that cascade that we talked about is shown here. And just to orient you, case investigation activities are going to be shown in green, and contact notification activities are shown in orange. And on the y-axis, we have the proportions that are positive, and then we look at each step in the cascade and we calculate the portion that's lost in the same way that Rick was doing in his talk earlier this morning. And you can see that there was a big drop-off in terms of just even to be able to telephone cases, primarily because a lot of time testing was done without collecting phone numbers. So if you don't have someone's phone number, you really don't have an opportunity to reach them. And then even once you telephone people, people wouldn't answer the phone, or they would answer the phone and tremendous amount of suspicion. You can imagine people calling during that time, were worried that people impersonating there was some type of scam, and others just feeling uncomfortable sharing their information with the government. In terms of contact notification, again, really big drop-off because a lot of contacts, if their cases weren't providing the information, couldn't actually be reached. But once that information was available, most contacts then did accept, because typically we think that the cases were letting them know that they would be called. Also, there were significant delays that accrued at each step. So this is what's called Vineland plot, which shows the distribution of the number of the time for each of these steps. These are the same steps that I showed in the previous slide for case investigation, for contact notification. Over here, you see the median number of days, and then the interquartile range. And what you can see is that every step kind of adds significantly to the time required to reach individuals, and that we're way beyond the period of time which the model suggests that we can actually benefit people by reaching them. And in addition to reaching only a low proportion, as we saw in the previous slide, we thought it was very unlikely that we were having any impact on transmission. What about in terms of our ability to stand up a program in a very, very short period of time, as we all remember? This shows here on the left side the program activity from the 4th of April up to the 30th of May. And what we did was we estimated, based on the number of cases that were identified in every week and on every day, we did some work, some surveys of the volunteers to say how long would it take them to do one of these calls. And we estimated the total number of volunteer personnel hours. And the black, kind of dark gray bar here shows the hours that were made available by volunteers. And you can see basically is that in every week except for the second week, the number of hours made available by volunteers exceeded the time that was made, the number of volunteers who were available. But because of this week came along, we had to get public health nurses and gray here to supplement the activities. The unfortunate thing was that the volunteers, though, were not retained at a high level. So this is the survival analysis. It's looking at the proportion of volunteers that were retained. And while some people were joining as time went on, the median time to remain in the program was only about 4 weeks. By the end of the 8-week period, most of the initial volunteers had dropped off and stopped working. In some cases, because it was the end of the semester, they were moving on. But also for reasons that you'll see in a little bit in a minute, for some of the experiences that they were having. So this is the results of our second investigation work for the focus group discussions with the volunteers. So this was a nested method study, so nested in looking with volunteers who were participating. And we did, I said 7, it's actually 6 focus group discussions. And there were 3 with case investigators and 3 with contact notifiers. Focus group facilitators were a couple of experienced qualitative researchers who were not involved in the contact tracing program. We wanted people to feel comfortable talking about their experiences, complaining if necessary, stating positive factors. And we also then did the analysis. We recorded and we did a thematic analysis and a deductive synthesis of the emergent themes using the Yale framework. So basically what we did is we got all the themes and then we said, which of these are related to reach, which are related to effectiveness, and so on. Because we wanted to be able to understand what were the barriers and also what were the opportunities or solutions that these individuals recommended. And we had actually 2 of the students who were doing this work were involved as telephone outreachers doing the telephone outreach themselves, so they were very familiar with all the data that was happening from their experience in the program, and they were supervised by a very experienced social scientist. Here's just a little bit about the volunteers. They're graduate students for the most part. There were a few faculty members. You can see the breakdown: public health students, medical students. People with clinical experience were primarily assigned a case investigation because it did involve taking clinical histories and being comfortable talking with people who actually had COVID-19 and might be sick themselves. Whereas the contact notifiers, this was mainly done by public health students. They did get some training in terms of interviewing, but this was often a little bit lower stakes than these types of interviews. And we got a good representation of the overall number of case investigators and contact notifiers. They were taken into account on a first-come, first-served basis. And these 6 focus groups took about an hour 15 to an hour and 30 minutes. So just some samples of the volunteer perspectives and experiences. it was a very intense time. On some level, the students felt left out because they weren't able to go to school, they were at home. Many of them obviously had a calling to be involved as medical providers or to do public health outbreak investigation. As someone who's always wanted to do outbreak investigation kind of stuff, I felt kind of powerless, and when this opportunity came up, it was like, this is something I could do. But also students found very, very quickly that it was hard work and very challenging situation. So I don't think any amount of training can really prepare you for that first call. And then I was doing this for about 4 hours a day. In addition to all the graduate school work and research and everything else, I got pretty burned out. The next day was like, I don't really know if I want to do this. And then finally, I think you just unfortunately have to account for the fact that volunteers who are trained might be gone 2 months later, and the training and volunteer turnover has to get turnover and go again. So students said that basically a volunteer program is not really sustainable, it's just a way of responding in an emergency. The volunteers also gave a lot of solutions. So here, for example, is providing ongoing tracer education, adding peer support. So there was kind of a feeling that just the one-off training and getting sent out to do the calls wasn't enough. There needed to be some support and mentoring them after. In terms of reaching the cases and contacts, adding a script about privacy, letting them know that their data will not be shared, integrating case and contact outreach. There was a lot of frustration, as you'll hear in a little bit, from the participants that they were getting multiple calls to the same numbers, saying the same things. And so they wanted to be a little bit more integrated. Personalizing the script so that it doesn't sound robotic was something that the students kind of learned as they went through the survey. And then because of the diversity of languages that are spoken in New Haven, trying to verify that up front, particularly times at a premium, because if they were calling and not able to speak, they would have to then refer it back to try to identify someone with language skills or a translator, so that led to additional delays. So these were some of the strategies that were laid out, and you can see how they came through in the form of the reading framework. We were able to feed this back to the New Haven Health Department very quickly by the end of May, or by the middle of May, so they can incorporate this into some of their ongoing activities. So the last thing is to talk about how the cases and contacts experience things. And we had 21 interviews with case investigators and 12 contacts. This is a little bit overweight. We had the same group doing the investigations. This was a different student who had Spanish language skills. She was involved in doing outreach and did interviews with the Spanish participants in this area. And for this one, we decided that a better framework to use would be the COMBI model, because we were trying to get at what were the barriers and facilitators and what were the motivations that these cases and contacts had to participate in the interviews. As I'll mention a little bit, one limitation of this inquiry is that if people didn't want to talk to us when we called them for contact investigation, they also were not really reachable for our formative research coming after, or evaluative research coming after. So there's a little bit of a selection bias. But we were probing to get a sense from these cases and contacts what they thought would be some of the reasons why people in their communities might want to participate in these interviews. So these are the participant types. You can see that we've got a mixture, about half were Hispanic or Latinx ancestry, and about 10% Black or African American, and some recommendations, some from other backgrounds. 64% were English speakers, and 36% were Spanish speakers. And here are the quotes from the cases and contacts. This is really giving a sense of about how well people adhere to the isolation and quarantine recommendations. From the day I started feeling sick, I just started to isolate. So this is a very adherent person. Here's kind of someone expressing that my wife was a little intimidated because she had a potential fear that her information was going to be manipulated somehow. So a lot of distrust and suspicion. A contact who tested positive said, I had no money to go shopping since the whole family was sick. And I had to put a mask on and just go to the store. So just an example of how people may be just not able to achieve both goals of looking after their families and adhering to the public health goals of isolation and quarantine. And then finally, just a person saying that she felt that a phone call wasn't really going to help her. She needed an actual doctor. And so in some ways, this outreach, it was helpful to some people, but to others, it just really wasn't enough given the gravity of the situation, the fear that people had, in a community where many people were becoming very very sick and dying even before they reach the hospital. So we ultimately were able to triangulate our findings. And so this is the idea, if you remember yesterday from Ashley Hagman's talk, that we take the findings of the quantitative, the qualitative, both from volunteer perspectives and client perspectives, and integrate it together. And some of the themes that came out is that the sustainability of the workforce was really limited, and that the technology didn't do all the things that we wanted to do in terms of collecting the data and being able to be able to analyze it. Second, that care was very fragmented for people not being able to link all lifetimes to the clinical services that they wanted, and getting multiple calls from multiple different places, and then non-adherence to isolation and quarantine being a big challenge. So some of the solutions to this that the volunteers suggested that came out, if you could just go to the advance the slide, that came out of this work were, if you just advance one more time. For the workforce sustainability, professional workforce and streamlined use of technology, integrated patient-centered care, and then incentivizing isolation and quarantine. We did some separate work looking at a program that employed people who were from these communities and trained them as contact investigators, who were familiar with the cultural beliefs of these peer group communities, particularly focusing on people with Polish language background, Spanish language background, and Haitian Creole were some of those. And that program was quite successful, but it wasn't broadly scaled up throughout the state. What are some of the strengths of this work, now kind of thinking about an implementation science perspective? Well, we pre-specified our research questions and we had prospective process measures, and that really benefited from the years of research that we've been doing on contact investigation and tuberculosis. It was very easy to adapt those to the COVID-19 context. It was also a strength that we were able to use multiple methods, as I showed, to get these insights, and that we were able to do multi-level evaluation, so looking at index patients, looking at context, but also looking at the health system in terms of how the services were provided. And then we used a community engagement approach to explore these multiple perspectives and feed those back to the public health system in fairly real time. That said, there were also some pretty major limitations. One is that this was just descriptive work. We really weren't in this emergency context able to think about randomizing people or assigning interventions in different ways to sort of see what things might work to make things better. There was a lot of selection bias, as I mentioned, in not being able to reach people who didn't want to be reached. We probably had a lot of measurement error in terms of how this data was collected because the systems were being evolved, the indicators were changing over time, and we didn't really have any of the meaningful health outcomes in terms of adherence, isolation, and quarantine. It would have been great if we actually had those measures to know how well ultimately the goals of this program were working. Also, this was a single-site study. The program shut down in June as it transitioned to a statewide program. So we weren't really able to carry the work that we did, the formative work forward to try to potentially get to testing new strategies. And the focus on the volunteer model was not ideal. Given that that was rapidly sort of discredited and people moved to the role of paying contact investigators as community health workers, which is appropriate. And people found other similar results. This is data from the UK, and this is from another study that also showed the challenges of doing contact investigation, particularly as the infection, COVID-19 has become more rapid in terms of its latent period and more infectious. It's become recently apparent that there's no way for contact tracing really to achieve the goals of containing infection, at least in a pluralistic society. So if interrupting transmission is not our goal, we have to kind of change the goal. And the way that we look at it is moving from serving all to serving the most vulnerable, because there are many people in Connecticut who don't need the public health system to support them. They're well resourced by their own knowledge, by their own primary care providers, by the insurance system, by their access. But maybe it makes more sense for the public health system to focus on people who don't have access to those things and do the things that it can uniquely do. I'll just acknowledge the Deeds Fund, the Yale School of Public Health for supporting this work. Tyler Shelby, one of our PhD students, and Rachel and I did a lot of work to analyze the data. And happy to take any questions at all.